Okay, but doesn't matter. So good morning. Today we are going to have a very important session that is on to clinical examination of foot and ankle, and with that we are going to do live. So live clinical examination of foot and ankle. And I have with me Dr. Neerav, who is a foot and ankle surgeon working with me, and Dr. Viral, who is a foot and ankle fellow from USA Columbus, and Neerav, who also is helping me, another Neerav, helping me into this, going live to you. So when it comes to foot and ankle clinical examination, I say that it's a rule of 3. Everything you do is 3 in number. For an examiner, he examines patient into sitting position, standing position, and into walking position. He does foot and ankle examination per se. He does examination of the gait of the patient, and he does examination of the footwear of the patient. So 3 examinations by clinician. And then 3 parts he examines: ankle and hind foot, midfoot, and foot. And he does 3 examinations: inspection, palpation, and manipulation. Now this palpation again has 3 things: topographic palpation, neurological palpation, and vascular palpation. So it's all rule of 3. And for a subject or for a patient whom we are examining, he is Dr. Neerav. He comes with the footwear on. Go and wear your footwear. He comes with the footwear on. He comes with his trousers lifted right above the knee. And he comes walking in the clinic, in the consulting room. So here is Dr. Neerav, who is going to walk down till the OPD room, and you examine him, you evaluate him the way he is walking, and he should come with the footwear on. And now can you remove this? And typically patient sits on a high table and examiner sits on a low height stool in a broad angle. Low height stool, and examiner is holding the foot of the patient in his lap. So this is the way. Even this table could be a little shorter than what it is, and this could be a little higher. So patient's foot is handled in the lap of the doctor. And this is how the clinical examination is being done. So now coming to proper clinical examination in itself. This clinical examination, you first start with the inspection and patient into the sitting position. Typically what I like to do, for a right foot, I like to go clockwise and proximal to this side. So for a right foot evaluation, I should have this side. For a right side evaluation, I like to go clockwise, and I start with the medial side, then I go dorsally, then I go on a lateral side, then I go onto the plantar posterior side, and then onto the plantar side. So this same chronology, if you follow, you may develop your own chronology, whether you want to go anti-clockwise, clockwise, all your call. But by and large, for a right side, I like to evaluate patient into clockwise position. Similarly, for the left side, again, you go anti-clockwise. So medial, dorsal, lateral, plantar, posterior, something like that. So you don't miss out. And then you do hind foot and ankle examination, you do midfoot examination, and you do forefoot examination. So this is how you go, so that you are not ought to miss anything. Obviously, the clinical examination, which I'm going to demonstrate, is going to be a long process. But even if you catch 70% of this clinical examination, then also you will not miss most often than not any important this. So when it comes to the inspection, most important is when you want to inspect the patient from different sides. Inspect patient on a medial side, inspect patient from the front, inspect patient from the side, and also go behind the patient and do the inspection. So your inspection has to be all around the patient. That is very, very important. Now, what do you inspect? In the inspection, the first thing you look is the alignment of foot with respect to ankle. Whether the foot is into varus, valgus, abduction, adduction. Then you look for the foot and ankle alignment vis-a-vis the alignment of the knee. So whether there is any angulation, whether any corneal plane or sagittal plane deviation. Then you look at the shape of the foot. How is the foot shape? Is that a small shape? Is that a long foot? Is that a foot which is kind of a deformed foot? So try to look at the shape of the foot, and if you are examining both the sides, always try and compare the one with the other. So that is about the shape of the foot. Then any gross swelling, any gross deformation, any scar, any skin graft marks, any discoloration is what you want to see. And you also want to see for the prominence of vein, which I think if you can come closer, if you do go for close-up mirror. Yeah, there are prominent veins here. So you look for the prominence of the vein. And the last but not the least, there are two things you want to look. That is the hairs over the dorsum of the foot. In the neuropathic patient, you do not have hairs, presence of hairs. And you have a skin which is shiny, and the luster of the skin, you feel that it is a shiny dust. And you also look at the nail, because nail examination also forms, inspection also forms an important part. Varicosities for you matters when it is more on a medial side, which is the common case, because if you are operating tarsal tunnel surgery, lot of varicosities are going to come. If they are there, they are going to come in your way, and you will have to cauterize them with the bipolar cautery. And venous edema, a limb with the venous edema would have long-lasting post-surgical edema, and patient could also have delayed healing. So if there is a venous edema, venous eczema, venous pigmentation, you can talk to your patient preoperatively that, look, you're going to have long-lasting edema, you're going to have post-surgical edema, and that he remains prepared for. So once you do the inspection, then you switch on to palpation. And your palpation is mainly by the index finger. And I say that two things for the clinical examination. One is history. History is his story. So your history, if you listen to the patient, then history will give you one or two diagnoses. So clinical examination would be focused on. And the second point I say about the clinical examination of foot and ankle is finger, index finger or thumb. Is that of yours, clinicians, or that of patient? So ask the patient where it hurts the most. So it is by his index finger he points out to that point. And then you, with your index finger or with your thumb, go for palpation. So now coming to the palpation for foot and ankle. And as I said, I will start palpating the ankle and hind foot. And can you come on from this side? You just sit down. So I'll start palpating from the medial aspect. And that is a very, very important topographic palpation we are starting. So first we'll talk about topographic palpation, then neurological palpation, and then vascular palpation. I start palpating the medial malleolus. The reasons being, palpation of the medial malleolus is very easy. is a subcutaneous bone. And most often than not, in foot and ankle orthopedics, where there are very few conditions like stress fracture of medial malleolus, like some kind of bone edema into medial malleolus, that medial malleolus would be tender. So if patient on palpation of medial malleolus winces, or patient says, oh doctor, I have a lot of pain, you have to take it with a pinch of the salt. There are patients who are malingering for some kind of industrial benefit. Now they are the one, they would show tenderness when you palpate onto the medial malleolus. So I start my clinical examination with palpation of medial malleolus. And then from medial malleolus, I would like to go anterior, below, and posterior. And always remember your anatomy. So if I go anterior to the medial malleolus, and it is at this point, can I have a pen? I think I have a pen. So Dr. Neera, I'm going to draw something on your foot. So it is this anterior area of medial malleolus, which would typically be tender when there is a deltoid injury. Because this is the area, anterior colliculus, from where you get an origin of superficial deltoid ligament. So deltoid injuries, patient would be tender onto the anterior aspect of, you're able to focus it properly? Yes. Anterior aspect of medial malleolus. Now, going down, if it is tenderness is immediately underneath the medial malleolus, then you think of involvement of deltoid ligament or involvement of the deltoid ligament. So from the anterior aspect of the deltoid medial malleolus, you can take your finger little up, and then where you go is called anteromedial gutter of the ankle. And it is this anteromedial gutter of the ankle which would be tender when patient has got malunited ankle fracture with a increased medial gap space, medial cases, or if the patient has got anteromedial impingement, he would have a spur which you would palpate into the anteromedial gutter of the ankle. And going down, you can also palpate a spur over the anteromedial aspect of the talus. From there onwards, you come down and palpate here. This is the attachment of the deep deltoid ligament. And if there is a deltoid injury, it can be tender. And then you go back and keep your thumb or finger flush to the posteromedial border of medial malleolus, and what you palpate is tendon of tibialis posterior, which is just adjoining, very close, is almost kissing flush to the posteromedial border of the medial malleolus. So your tibialis posterior tendon, and this tendon is very important for your assessment of acquired flat foot. If you have a tibialis posterior tendon rupture or injury, it could be tender, or even a flat foot. It could be tender going right up to the lower third of the leg. It could be tender. So this is the clinical evaluation near medial malleolus. From medial malleolus, from tendon of tibialis posterior, if you go little back, just adjoining to it is tendon of flexor digitorum longus. So herein would be flexor digitorum longus. Then you will palpate the neurovasculars, and the last palpation would be tendon of flexor hallucis longus. So we used to say Tom, Dick, and nervous Harry. So it is tibialis posterior, flexor digitorum longus, neurovascular, and your flexor hallucis longus. Now, when you have a problem into the flexor retinaculum, tarsal tunnel problem, the flexor retinaculum passes like this from the posterolateral medial border of the tibia. It goes right up to the calcaneus. And this area, if it is tender, there is something wrong into the flexor, into the tarsal tunnel. Sometimes if there is a space occupying lesion like a ganglion or a tumor, you can palpate it here, and this could be tender here. So palpation of the tarsal tunnel. And then when you come anteriorly, from medial malleolus, the first bony prominence which you palpate is navicular tuberosity. And it is at the navicular tuberosity that you have insertion of tendon of tibialis posterior, which curves around the medial malleus. Now, navicular tuberosity, if the accessory navicular is there, it would be tender. You would palpate a big bump. If the tibialis posterior, many cases, they start with insertional tibialis posterior tendinitis or tendinosynovitis. You would be able to palpate some tender point, and if you follow upwards over the course of tibialis posterior, then you will also find tenderness and swelling into the tibialis posterior. So, as I said, the first bony prominence after medial malleolus is tibialis posterior. Now, one of the very important bony prominence which you must know to palpate is sustentaculum tali. Because whenever you are passing your screw into calcaneus for an article, you want to engage the sustentaculum tali. Or you have a posteromedial variety of talar fracture, or you want to go for a posteromedial approach, you need to know where is the sustentaculum tali. If you want to reconstruct spring ligament for acquired flat foot cases, then also you need to know where is the location of sustentaculum tali. So, the sustentaculum tali is palpated halfway and a finger breadth below the medial malleolus and navicular tuberosity. So, if you take a distance between these two halfway and you go a centimeter below the bony prominence, yes, I am palpating it here. And you all can palpate in your foot that a medial malleolus, sustentaculum tali, halfway and a centimeter below is your sustentaculum tali. And it is at this sustentaculum tali that your tendon of flexor digitorum longus passes. So, if you are to take this sustentacular approach or a medial approach for addressing sustentacular fracture or for addressing calcaneus fracture, sometimes you need to take a medial approach. It is that sustentaculum tali is a bony prominence which you are going to identify, and once you take your flexor digitorum longus up or down, you would be at the sustentaculum tali. So, on a medial side, this is how you evaluate ankle and hind foot. Now, some very important clinical palpation is the palpation of the anteromedial border of tendoachilles. So, you palpate anteromedial border of tendoachilles, and particularly a very, very important palpation. I saw that in group we were discussing a lot about a case of plantar heel pain. And we are going to discuss that into day-to-day orthopedics. But the most important thing I feel for successfully managing a plantar fasciitis or plantar heel pain case is to come up with the etiological causes of heel pain. So someone was asking whether this patient has got hypothyroidism or gout or not, right? So every possible etiology you have to label out and you have to do an etiological diagnosis. So say etiological diagnosis could be a case of neuritic plus fascial variety of plantar, or case of plantar fasciitis with a malunited calcaneus fracture with plantar heel fat pad atrophy in a case of an obese patient, something like that. And all 4 or 5 etiologies you have to deal with to be successful at clinical examination and treating the patient. So, we all know that the posterior tibial nerve divides into multiple calcaneal branches. And so if I draw the posterior tibial nerve divides into multiple calcaneal branches and then into 2, where an anterior branch is a medial plantar nerve and the posterior branch is a lateral plantar. And medial plantar nerve goes quite anteriorly and passes underneath the anterior portion of the abductor hallucis. And the lateral plantar nerve gives a branch and it passes underneath the deep fascia of abductor hallucis muscle, where it starts. And this nerve gives a branch, which is a branch to nerve to abductor digiti minimi. It is also called as nerve to abductor digiti quinti. It is also called as Baxter's nerve. It is also called as first branch of lateral plantar nerve. It is this first branch of lateral plantar nerve. When it gets compressed, patient will get heel pain irrespective of his or her activities. So mechanical heel pain, which is because of the plantar fasciitis, typical plantar fasciitis heel pain would be at the medial plantar tubercle of the heel, from where the plantar fascia gets origin. So typical plantar fasciitis pain would be here at medial tubercle of calcaneus, and the pain which is because of pressure onto nerve to abductor digiti minimi is at the medial plantar aspect of the heel. And you should be able to differentiate a neuritic pain, facial pain, because both could be present, or one could be present, another could be absent. So how to diagnose the neuritic plantar heel pain? You start your palp. See, look this very, very carefully. And this has to go in our DNA. So we start palpating from the posterior aspect of the calcaneus and posterior aspect of the heel. And what you palpate here is the bone, calcaneus bone, medial surface. Again, you go anteriorly, palpate, you're palpating bone, go anteriorly, still you're palpating bone, go anteriorly, you're palpating bone, go into O, and suddenly there is a give way. This point where my thumb is, I hope all of you are able to see. If you have any problem, stop me in between. As I said, this should be a dialogue. Okay. So my thumb is at what is called a soft spot of the heel. This is the soft spot of the heel. And if this spot is tender, that means this patient has got neuritic variety of plantar heel pain. So you must have noticed that there are many patients who come to us and say, doctor, I have got a pain on a lateral aspect of the heel. This is typically because of pressure over nerve to abductor digiti minimi. This is how the abductor digiti minimi travels. So a nerve supplying to this, when it gets caught here, when it gets compressed here, patient will have pain on a lateral border of the calcaneus or heel. So this soft spot, if it is tender, that means it's a neuritic variety of heel pain. Going forward, I will show you some, I will take videos of some cases, and where I start for a plantar fasciitis, I will start my palpation right from the top. So I like to be little closer to the tibia, and I start palpating the posterior tibial nerve right from here. And there are some patients who has got tender posterior tibial nerve above the level of flexor retinaculum. That patient requires total, complete tarsal tunnel release. And sometimes these patients also have proximal radiation of the pain, neuritic pain, and this is called as Wallich's phenomenon. And if that is there, it's a very severe variety of tarsal tunnel compression. So it is a proximal radiation suggesting that there is a huge amount of or grave amount of compression at tarsal tunnel syndrome. So what I do, I start for a plantar heel pain case, I start my palpation right from the top, from the posterior tibial nerve, and I palpate both the nerves, branches of both the nerves. And for a soft spot, I start posteriorly and come anteriorly. And suddenly, if I ever give way, if this is tender, I know that this patient has got neuritic variety of plantar heel pain. Instead of giving him painkillers, I'm going to give neurotropics to this patient. And I'm also going to elicit the history whether this tenderness radiates this pain, this pressure gives pain here here or not. That means also if there is a shifting pain, if there is a radiating pain, it's a neuritic etiology. So you could have a facial plus a neuritic etiology where you have to push your patient with neurotropic plus something for this. So that's on a medial side of the ankle and hind foot. We will also take media. We'll also go ahead with the examination of the heel per se. So for a heel pain, the location of the pain gives you the etiology. So if you have a heel pain which is onto the plantar posterior aspect, that is because of some kind of a Haglund syndrome. If you have pain which is into the center of the calcaneus, it could be because of calcaneal stress fracture. You have a pain at soft spot, it is because of the neuritic variety of plantar fasciitis. If you have a pain which is above and into the center between the medial malleus and tendo Achilles, pain is here, that means you have tarsal tunnel syndrome. If you have pain which is plantar medial over the calcaneus tuberosity, medial calcaneus tuberosity, this is purely a plantar fascia pain, purely a plantar fascia pain. So, and sometimes you have swelling and tenderness all across the abductor hallucis, and that is because of hypertrophy of abductor hallucis. I've seen 2 cases in my career where patient could have pain. So location of the pain in itself could be the guide for the cause of heel pain. Patients who has got plantar, there was a lot of discussion about heel pad atrophy. So heel pad atrophy, where the pain is plantar central, it is heel pad atrophy. You compare this heel pad with the opposite side, you compare this heel pad with your own heel pad, and if you find that this heel pad is reduced into the size and is not that cushioned like the other side, that means there is a heel fat pad atrophy. Patient would have pain which is into the center. Patient could have proximal plantar fasciitis and patient could have distal plantar fasciitis. All those patients who have pain at the insertion of plantar fascia, it is proximal plantar fasciitis. Plantar fascia pain could also be there distal to the insertion because the plantar fascia travels like this. So this pain is pain because of distal plantar fasciitis. Well, when you evaluate a plantar aspect of the heel, you also look for the presence of ecchymosis. Any trauma, midfoot trauma case, you must look at the plantar aspect of the foot to see for the ecchymosis. And if ecchymosis are there, that is the surest sign of a Lisfranc injury, where Lisfranc ligament has got injury, and the hematoma settles down here, and you will have ecchymosis underneath the mid part of the plantar aspect of the foot. The ecchymosis which are into the midfoot are because of Lisfranc injury. But if you have ecchymosis which are not into the midfoot, which are proximal to midfoot, that is because of plantar fascia rupture. So when somebody has inadvertently given a local steroid or some shockwave therapy has been fired beyond the dosage which normally should be given, there could be rupture of the plantar fascia. So plantar fascia rupture, you will have ecchymosis which is proximal, and Lisfranc injury, you have ecchymosis which are distal around the Lisfranc joints. So this is a plantar examination, and now I am going to move to the dorsal examination. On the dorsal examination, the first tendon which you are able to palpate is tendon of tibialis anterior, which is lying the most medial. This is the most medial tendon. Then the next tendon which you are able to palpate, sometimes in a thin and lean individual, it is easily palpable. I am able to palpate it here. When I am moving the great toe, it is extensor hallucis longus. And the vessels, they remain lateral to the extensor hallucis longus. Almost they are between extensor digitorum longus and extensor hallucis longus. So once you palpate the extensor hallucis longus and you are able to palpate extensor digitorum longus as a mass of the tendon, vessels are exactly halfway between them and they are quite posterior. So when you want to give some injection to block the deep peroneal nerve, you need to go quite deep up to the bone and then you need to withdraw your needle and inject here. So tibialis anterior, extensor hallucis longus, vessels, extensor digitorum longus. Now this is very important for us to know because the most commonly used approach for total ankle replacement is the anterior approach, which is between the tibialis anterior on a medial side, extensor hallucis longus, vessels, and extensor digitorum on a lateral side. So you're going through the sheath of extensor hallucis longus and retracting EHL, vessels, and EDL on a lateral side and tibialis anterior on a medial side. The another significance is when you are wanting to take arthroscopy portal. Now, arthroscopy portal, what you do is there are two very commonly used portal, anteromedial portal and antero. Somebody wanted me to talk onto arthroscopy. We will be talking about it, but this time today we have a clinical evaluation. So that time we can definitely talk about the portal. So you start palpating the distal tibia and your thumb palpates tibialis anterior on a lateral aspect of your thumb. And then suddenly, when there is a soft spot or give way, it is the ankle joint. And you can move your ankle into plantar flexion and dorsiflexion. You can palpate the movement of talus. So when you palpate this is the anteromedial portal. So which is medial to medial malleus, but lateral to medial malleus, but medial to tibialis anterior. Sometimes you can just mark the tibialis anterior by doing dorsiflexion and see in the dorsiflexion, you can see tibialis anterior is prominent. In the plantar flexion, it moves laterally. So once you do the dorsiflexion, you do the plantar flexion, you mark the tibialis anterior and palpate your soft spot. And here is your anteromedial portal for the arthroscopy. Now, if you go little down, you palpate the dome of the talus. And that time you should be plantar flexing the ankle. And so you're palpating medial, posteromedial dome of the talus right into the joint space with the ankle plantar flex. This is the very, very common site of osteochondral lesion. OCDs, 75% of the OCDs are on an posteromedial dome of the talus. So this is what you do. And you can palpate extensor digitorum longus here. And once you palpate the EDL, you just put in a mark there. Again, start dorsally and come down, and suddenly there would be a give way. And this give way is nothing else, but it is the soft spot of the lateral ankle. And this is the place where you are putting your approach and for anterolateral portal. Anterolateral portal has to be taken carefully because it is the area through which a superficial branch of peroneal nerve comes into play, which I am just going to come later. So this is about the dorsal. And okay, going down from the talus on a medial aspect, what you palpate is your so going down, what you palpate here is your talonavicular joint. So talonavicular joint would be just going down the ankle and you have passed the talus and you come to the talonavicular joint. What you can do to palpate the talonavicular joint, you could also put your one finger or thumb onto the tuberosity of navicular, and then from there you can slide it up and dorsally. This is the area where you will have your talonavicular joint. This will be the head of the talus, and this would be the navicle. And you can palpate your talonavicular joint. The medial aspect, going outer aspect, you will be able to palpate your lateral aspect of the talonavicular joint. So that's about your medial, dorsal, and plantar aspect of ankle and hind foot topographic palpation. Now I'm going to go on to the lateral aspect of the foot and lateral aspect of ankle rather. And this forms a very important palpation. Nirav, can you come like this? I think you are able to see properly.
Yes, sir.
Yes, sir.
Yes. Okay, okay. I thought I lost you. Okay.
No.
So again, on the lateral aspect of the ankle, the first thing you palpate, where you can come on this side for better visualize. So for the first thing which you palpate again here is your lateral malleolus, tip of the lateral malleolus and the lateral. So this is the lateral malleolus which you are very easily able to palpate. And your palpation starts from the lateral malleolus. You could go a little up and palpate the lower third of fibula. But the most important thing here would be to go anteriorly and palpate syndesmotic ligament. What I do, instead of going up, I start going below. And from lateral malleolus, as I pass my finger anteriorly, this is the area where anterior talofibular ligament starts. So if I go anteriorly into this area, this is the place where my ATFL, anterior talofibular ligament, which is going into the neck of the talus, will be lying down. And this is a very, very important ligament, and this is a very, very important palpation that for this commonest injury. So ATFL goes like in this direction, and you can palpate from the tip of the fibula, you can palpate ATFL. Going further up, what you are traversing into is the lateral, anterolateral gutter of the ankle. So this is the talus. Here is the gutter of the ankle enter. Now this is the anterolateral gutter which gets commonly impingement or fibrosis or adhesions because of improperly treated ankle sprain. And many times you need to go in and do the clearance of this anterolateral gutter. So anterolateral gutter palpation is very, very important. And from there, when you go up, this is the tibia, here is the fibula. And if you go up, then what you encounter is syndesmotic ligament. And syndesmotic ligament, so if I draw the fibula, if I draw the tibia, somewhere over here are AITF, anterior inferior syndesmotic ligament. So even if whenever you're doing some test to evaluate syndesmotic instability, you're using this point to elicit the tenderness, pain, something like that. So AITFL, anterolateral gutter of the ankle. Slight anteriorly, you are onto the anterolateral aspect of the talar body. Now, the lateral osteochondral lesions, OCDs, are anterior. The medial one are posterior. So if you have lateral OCD, which is like 20%, less than 20-25% of the OCDs are on the lateral side. So herein you would find it tender with patient's ankle into the plantar flex. So tip of the lateral malleolus going anteriorly, ATFL, anterolateral gutter, talus per se, and syndesmotic ligament. Now, when you come down from the tip of the fibula, now this is the place where a very strong calcaneofibular ligament would be passing. So tip of the lateral malleolus is somewhere over here, and calcaneofibular ligament goes right directly over the calcaneus. And posterior to the lateral malleolus, you would be able to palpate your peroneum. And here there are two peroneum, peroneus brevis and peroneus longus. And you know, brevis to bone. Longus is a long tendon which is away from the bone. So brevis is kissing the bone and longus is above it. So this area is, if you have a tenderness, definitely you know that there is some kind of tendinosis, tenosynovitis, or a tear of peroneal tendon. Now, if you have pain, swelling, tenderness, which is diffuse underneath the underneath the tip of the fibula, you know that this swelling and diffuse tenderness and diffuse swelling is because of subfibular impingement. In cases of acquired flat foot, where patient's heel goes into valgus and the structures between the tip of the fibula and the lateral surface of calcaneus gets caught, and there is tenosynovitis of the peronei. There is pressure over the calcaneofibular ligament, and this gives a subfibular impingement and some swelling, diffuse swelling over here. Going little anterior to this place is your sinus tarsi. So if patient has got pain, swelling, tenderness here, it is suggestive of one of the rare conditions called sinus tarsi syndrome, right? So this is the place where you will find a dimple. It is for the sinus tarsi, where you have a space between talus above and calcaneus below. Now, tip of the fibula, if you go down, you palpate peronei, and if you go still down, you are able to palpate a bony protuberance, and this is called peroneal tuberosity. You must palpate the lateral border of the calcaneus. For any prominence, malunited calcaneus, you will feel exostosis here. Sometimes you have some swelling over here, and here, this is the place where you have a prominent tubercle through which a tendon of peroneus longus goes, and that is a posterior, that is a peroneal tubercle. And hypertrophy of this tubercle can lead to pain, tenosynovitis of peroneus longus, sometimes tear of peroneus longus. So that is on the lateral side. You also palpate the lateral border of the calcaneus. Going anteriorly and dorsally, you will palpate a bony prominence, and this bony prominence is just below the sinus tarsi, and that is the anterior process of calcaneus, from where your calcaneocuboid joint starts. So this is the anterior process of calcaneus, which would be a bony prominence. You would be able to palpate. And going distally, what you would be able to palpate would be a bony prominence at the base of fifth metatarsal, that is a fifth metatarsal base. Your peroneus brevis tendon inserts here. Your peroneus longus tendon goes underneath this into what is called as a cuboid tunnel, and from there peroneus longus goes and inserts into the base of first metatarsal. So on a lateral side, you also have, look at the lateral border of the tendoachilles, and any swelling which is, now this is where we are coming to a very important clinical evaluation for the posterior heel pain, and I would request Dr. Nirav to get into prone position so it will be more easier. Thank you, Doctor. Yeah, so keep it like this, keep it like this, keep it relaxed, keep it relaxed, keep it relaxed. So for a posterior heel pain, there are multiple etiologies. All of them could be present together, or there could be presence of one, there could be presence of two. You should be able to clinically differentiate that what all etiopathologies you are dealing with to perfectly treat a case of posterior heel pain. There are two bursa. One bursa is anterior to calcaneus, anterior to tendoachilles, and above the level of calcaneus. And this, my two thumbs are depicting retrocalcaneal bursa. So if you have tenderness swelling, which is above the level of calcaneus and anterior to tendoachilles, this buoy swelling is retrocalcaneal bursitis. If you go down and you have a bony prominence and it is tender anterior to the insertion of tendoachilles over the calcaneus at a posteromedial or posterolateral corner of calcaneus, this is Haglund's deformity. Though we use a term Haglund syndrome, which says everything, but I think we should be able to differentiate that whether this is the case of only retrocalcaneal bursitis or it is a case of retrocalcaneal bursitis with Haglund syndrome, Haglund's deformity. Then there is a bursa which is between the skin and the insertion of tendoachilles. This is called Achilles bursa. So sometimes you have a swelling, pain and tenderness, a buoy swelling, pain and tenderness here, which is between the skin and tendoachilles insertion. That is Achilles bursa. That could be Achilles bursitis. Now coming to the insertion of tendoachilles. Now when you start palpating bone, calcaneus bone, and go up from the plantar, posterior below up, you are able to palpate a bony projection. This bony projection is called insertional calcaneal spur. This is insertional spur. And this could be prominent. And if it is prominent, it would impinge over the tendon and it would give rise to what is called as insertional Achilles tendinopathy or tendonitis or tendinitis. So insertional spur. And then when you go above at the level of insertion of the tendon, and you can also palpate tendon between your fingers. If this is tender, if this is nodular, if this is irregular, that means this patient has got insertional Achilles tendinitis or tendinopathy. I hope I'm getting clear. If there is any doubt, let me know. Insertional spur and insertional tendinopathy. If patient has got pain, swelling, inflammation, tenderness, which is 2.5 centimeter above the level of the insertion of Achilles, and you palpate tenderness or nodularity in Achilles, this is called non-insertional Achilles tendinopathy, which is common into sports population and common into what we call old aged people, a weekend warrior who again starts suddenly doing workup on the weekend and gets pain. So this is an area of non-insertional Achilles tendinopathy or tendinitis. This is the area for insertional spur, and this is the area for insertional Achilles tendon. So this is where the palpation of the posterior part of the ankle becomes very, very important and vital going from the lateral to the posterior. So thank you, Doctor. So we have discussed ankle evaluation. Now we will discuss midfoot, and we'll also take together with it forefoot. So on a medial aspect of midfoot, so if you ask patient to do inversion and eversion, you come to know about the insertion of tibialis anterior. Now this is one of the very important landmark surgically, because it is halfway at the posteromedial aspect of middle cuneiform that the major insertion of tibialis anterior is there. So when you are able to palpate tibialis anterior and its insertion, you know that this is the medial cuneiform, and thereby you are able to palpate the rest of the thing, and you are able to put your incision. Now, when you want to palpate Lisfranc joint, the most important thing is you should start distally and then you should come proximally. So this is the way you start distally from the palpating the metatarsal, because distally the bones are thin, subcutaneous. You are able to palpate and go up, go up, go up, and suddenly at the Lisfranc joint, if there is a pain, tenderness, yes, you know that there is a Lisfranc. Similarly, second metatarsal you want to palpate, you go from palpating the metatarsal shaft, go up go up, and this joint is little more proximal than the other joints, and then this is your second. At the same time, suppose you're still in a doubt, what you can do is called as a piano key maneuver. You can hold metatarsal into thumb, between thumb and index finger, and manipulate metatarsal. And if it moves here, right, that means that you are near that joint. So that is what you can do. You can do piano key test, piano key maneuver for all other metatarsal. So first, second, third, fourth, fifth is what you can palpate going from distal to proximal. So that essence is the topographic palpation for the dorsal aspect of the midfoot. Plantar aspect of the midfoot, we did discuss palpation of the plantar fascia and abductor hallucis and abductor digiti minimi on a medial and lateral side. Plantar fascia palpation, for plantar fascia palpation, what you do is called as jack stace. So jack stace is like dorsiflexing all the toes, and then plantar fascia becomes prominent, and you can palpate plantar fascia for any nodule, any abnormality, and some kind of tenderness or swelling here. Plantar fibromatosis is one of the common conditions where patient would have swelling, tenderness, nodularity of plantar fascia. On a lateral aspect of midfoot, yes, obviously you have your fifth metatarsal, fourth metatarsal, and I did show you the calcaneocuboid joint. Coming to the topographic palpation of the forefoot. In the forefoot, the first topographic palpation you start is going from up to down over the first metatarsal. You go onto the metatarsal head, and then suddenly there is a soft spot, and this is for the metatarsophalangeal joint. So metatarsophalangeal joint can be palpated dorsally, and you can move your great toe in palpating. Here you are palpating for any evident osteophytes, like in case of hallux rigidus, you have osteophytes which are prominent and rubbing over the tendon nerve, and patient could have tenderness. So stiffness and tenderness is what you would notice into hallux rigidus. So you palpate the first metatarsophalangeal joint. You can palpate the base of the phalanx for any prominence, any. And similarly, you could palpate the second metatarsophalangeal joint, third, fourth, and fifth. But the plantar evaluation is very, very important. You palpate the plantar skin with your index finger for any thickness, con, callosity, and locate the callosity and con. Where is the location of con or callosity? And the location of con or callosity is very, very important. We will give due attention to what I am trying to say. See, if you have a con or callus which is directly beneath the head of the metatarsal, that means this metatarsal is little plantar flexed and is giving a lot of pressure. And that is why you have a discrete type of callus here. If you have callus, so this is the metatarsal head, and you have a callosity here, or you have a second metatarsal here, and you have a callosity here, which is a discrete callosity. That means it is the pressure of the metatarsal which has given rise to this callosity. And there could be multiple reasons. You could even have stiff tendoacheal, you could have a cavus foot, all these things. So in such case, when you have a pressure over under the head of the metatarsal, you have to do a procedure which lifts up the metatarsal. So you have to dorsiflex the metatarsal. And when you have a callus, con, callosity which is diffuse and which is like diffuse callosity and distal to the head of the metatarsal, that means this metatarsal is having abnormal length. And it is an issue of the length which is giving rise to this. And then you need to do metatarsal shortening also. And mind you could have both. Then you need to do metatarsal shortening plus dorsiflex. I hope all of you are clear about it, because this is very, very important to look at the plantar aspect and decide where the callus is, where is the presence of callus, and palpate the callus, whether you are able to palpate your metatarsal head underneath the callus or not. In forefoot, you evaluate for the tenderness, swelling, some obvious deformity. If there is a deformity, you manipulate the deformity, whether the deformity is correctable or not. Suppose patient has got hallux valgus, then you try to correct hallux valgus, whether it is correctable or not. Hallux varus, you try to correct it, whether it is correctable or not. Patient has got a hammer toe, you try to see whether it is correctable or not. So correctability of the deformity and repositioning of the toe has to be evaluated when you're doing topographic palpation for foot. I guess we have covered complete topographic palpation. Then the next palpation is vascular palpation. And obviously we know that we have to we know how to palpate dorsalis pedis. We know how to palpate anterior tibial artery. We know how to palpate posterior tibial artery. But dorsalis pedis artery must be pre-operatively marked whenever you are operating a Lisfranc case. So you always have an idea that, okay, here are my vessels. So that is the significance of it. And obviously diabetic patient, you want to see the vascularity of the patient. But the most important thing which we forget, which we miss, is the nail bed circulation. So nail bed circulation is equally important after surgery. Once you release the tourniquet, more so particularly if you are doing closed surgery, and more so if you are doing rheumatoid foot surgery, you must be very keen and cautious into looking at the digital circulation, and that is very, very important for palpation, which is a vascular palpation. And then comes the last palpation, which is neurological palpation. So in neurological palpation, you look for the sensations, you look for the reflexes, you look for individual muscle evaluation, and you palpate certain nerves. Now, anterior to the medial malleus, just together with the vein, you are able to sometimes palpate a nerve, which is saphenous nerve. And when you are giving ankle block, you need to block this saphenous nerve. When you are doing a talus surgery, you have to be watchful that you don't injure. When you're doing medial malleus surgery, you're putting a plate on medial malleus, you must be watchful not to injure saphenous nerve. Otherwise, patient would have an area of hypoesthesia and sometimes neuroma would repay. The most important nerve which we need to palpate is superficial peroneal nerve. Now, this nerve can be palpated by plantar flexion and inversion of the foot and that of the fourth toe. So if you can see what I am doing, plantar flexion, inversion, and the fourth toe I am bringing into plantar flexion. And in a thin and lean individual, like 60% of the individual, you are able to see and palpate the superficial peroneal nerve. And it goes something like here. Now, this is a very important nerve which we need to take care of when we are doing pilon surgery. When we are doing ankle arthroscopy, usually the portal is medial to the nerve. And sometimes with the light glow, you are able to see the nerve. So the most important thing for taking care of nerve in foot and ankle surgery, more so at ankle arthroscopy and midfoot surgery, is nick and spread technique. You put in a nick, you spread it vertically so that you don't injure the nerve. And look at the cutaneous nerve, salvage it, and then go by the side of it. So whenever you're putting a scope, light could also be seen, and sometimes in this light you are able to see the nerve and you can preserve the nerve. The most common complication of ankle arthroscopy is injury to the superficial peroneal nerve. So superficial peroneal nerve can be palpated, can be seen in many of the patients. You have a sural nerve here between medial malleus and the anterior border of tendoachilles. Your deep peroneal nerve comes here, your anterior peroneal nerve comes here. So deep peroneal nerve, we are going to discuss the blocks. How do we block it? And I'm also going to discuss about the posterior tibial nerve block. So posterior tibial nerve block is what I use as secondary modality for treating my plantar heel pain patient. So the case which you people were discussing, I think posterior tibial nerve block would be justified. We'll discuss that case once we finish the clinical exam. So that's about the palpation of the nerve. Now, and you could palpate sensations, pain sensation, deep touch sensation, superficial touch sensation. Sometimes vibratory sense is very important to palpate when you want to diagnose early neuropathy in foot and ankle. So there is a machine called biothesiometer where the probe itself gives vibration. You put it at various points on foot and ankle, and you ask patient whether the patient is perceiving it or not. Accordingly, you know about the vibratory sense of the patient, which is the first sensation to go in neuritic or neuropathy cases. So then we go to evaluation of individual muscles. How do we evaluate individual muscles in foot and ankle? And the most important muscle which you want to evaluate the strength of is tibialis posterior, because many times you want to transfer it for the drop foot. So you ask the patient to put the limb onto the opposite thigh, and foot is kept into plantar flexion, and patient is asked to invert the plantar flex foot, and you palpate tibialis posterior, and then, or you put foot into this position and ask patient to maintain this and not allow you to correct this, and you palpate his tibialis posterior, you can palpate the strength of the tibialis posterior. Similarly, for tibialis anterior, you put the limb into dorsiflexion and inversion and ask patient to maintain this position, and you can palpate tightness of tibialis anterior. I don't go into extensor auditoris longus, PDL, FDL, FHL, and tendoachelis. This all you know. But I would definitely go ahead with evaluation of peroneus longus and peroneus. It's very important that we need to learn, and we need to clinically diagnose that yes, here is the weakness of only peroneus brevis. Here, this patient has got weakness of peroneus longus. So peroneus brevis is strong everter of the foot. So in a neutral position, ask the patient to evert the foot, and you put the pressure, and your hand is over the peroneum, and you are able to feel the tightness of peroneus brevis. You are also able to palpate the peroneus brevis, and you are also able to learn about the strength. But you want to differentiate, sometimes the peroneus longus also contributes into it, but you want to differentiate about the strength of the peroneus longus. Then you ask the patient to push the great toe, and not only push the great toe, but in an everted foot, ask him to push the great toe. And this great toe push is mediated by the peroneus longus, which gets inserted at the base of the first metatarsal. Its function is the plantar flexion of the first metatarsal. So this is about the muscles. And the last part of your foot and ankle examination is evaluation of the movements of the joint. And movements of the joints, when you want to evaluate, it is active movement, which patient does, and the passive movement. What I am going to demonstrate is very, very important evaluation, is the evaluation of the passive movements of various joints. And the first joint which you want to evaluate passive movement is ankle joint. And how you do it, that patient's wrist, patient's heel is in your palm, and you are correcting varus or valgus. You don't allow patient to keep it in the valgus or varus. See, and let patients put rest on the volar aspect of your forearm, and then slowly take the ankle into dorsiflexion and into the plantar flexion. This is the way. After correcting heel into neutral, you are looking at the ankle dorsiflexion and plantar flexion. Similarly, when you want to look for the subtalar joint movement, again you hold the heel in the palm. The foot of the patient should be resting over your volar aspect of the forearm, and you put your thumb and index finger into the talus and make sure that the movements are not occurring at talus, but movements are occurring at the subtalar joint, and do inversion and eversion. Sometimes if the subtalar joint is arthritic stiff, patient would have movement which would occur, which would be less than this movement, but which might occur at the talus, and you are able to appreciate that here. Then comes the movements at transverse tarsal joint, talonavicular and calcaneocuboid joint. These are very small movements, but this jog of movement, if you want to appreciate, put your thumb and index finger onto talus and take the foot in your hand and try to do abduction, adduction at this joint. These joints have little abduction, adduction. If the joints have got arthritis, you try to manipulate joint into internal and external rotation. That would be painful. But this small little abduction, adduction movements are the movements which occur at transverse tarsal joint. There is also some amount of dorsiflexion, plantar flexion, which also occur at this joint. Then coming to the movement of the tarsometatarsal joint, as I said, you go on palpating tarsometatarsal joint, hold the metatarsal between the thumb and the middle finger, and do piano key maneuver and appreciate the movement. It's a very little movement here. Movement of metatarsophalangeal joint, passive movement, hold metatarsal with one hand proximally and take the thumb, take the great toe in other hand, and then you passively take it into the dorsiflexion and plantar flexion. Similarly, you want to appreciate the MTP joint movement, you're doing same. And your thumb is at the base of the proximal phalanx, so you are also able to appreciate whether the proximal phalanx is moving or not. Most important thing would be to maintain rest of the joint into the neutral position and do this movement. Similarly, for the PIP joint and DIP joint, you do the passive movements of the joint. So that's manipulation. And so this is what we do into the sitting position. Now you want your patient to stand and you want to evaluate him into the standing position. Go a little back. Yeah, stand. So in a standing position, you need to move all around the patient. In a standing position, you look for the alignment of foot and ankle vis-a-vis knee, hip. You look for the alignment of midfoot, forefoot vis-a-vis hindfoot. You see patient from the front, you see patient from the back, so that you are able to appreciate varus or valgus. The commonest mistake I notice to the cases which come to me as a secondary referral cases is that patient has never been examined or evaluated in a standing position. So standing evaluation is very, very important. Believe me, you would see a lot of miracles. The foot might drop into varus, valgus, abduction, adduction, and look at the arch, medial longitudinal arch, look at the transverse arch, go to the side, go to the front, go to the back, go to the medial side. Alignment, shape and size, any deformity, pains, arch is what you need to see. Arch is one which you can even manipulate, you can even palpate the arch, how arch is going up or down. So that important evaluation should always be part of your evaluation. So once you have done a foot and ankle examination per se, Now you have two evaluation to be done, and the important evaluation is that of the gait of the patient. So focus on me, and then focus on my foot. Focus. So gait, typically you want to look at the symmetry of the part, the symmetry of the movement of the hip, knee, back, and symmetry of the shoulder movement, whether the gait is hurried or not, or what part of the gait is short, which part of the gait is long. Because typically we have a foot flat, we have we have a heel strike, we have a foot flat, and we have a toe off. Though recently gait cycle is divided into more number of segments, but by and large these three are the major segment, and you need to look at the stride length, how long steps are being taken by the patient. So look at the gait and look at the patient's face also while patient is walking, because in an antalgic gait, patient would immediately try to lift up the affected foot and ankle, and he would be spending very less time of foot flat when there is painful condition in the foot and ankle. So this is a typical of antalgic gait, where whenever he puts the foot, he winces and he takes that weight off. Another important gait, you go far. Another important gait in foot and ankle is a drop foot gait. So in a drop foot, patient needs to lift and flex the knee to clear the ground. So this is the way patient who has got drop foot is going to walk. Then you have gait, which is a circumflexion gait. When you have an iliopsoas weakness, patient would walk with circumflexion gait. You have a gait which has got a lurch because of the gluteal weakness. So whenever patient walks, he lurches. But the most important gait, which I think we should be able to appreciate, is a gait where you have a lateral ligament laxity in a cavo-varus foot. So in a cavo-varus foot, you focus onto my left, you see my left side. So in a cavo-varus foot, patient has a lateral instability and lateral thrust. So whenever he walks, he has a lateral thrust. And similarly, if patient has got injury or rupture of the tibialis posterior, he doesn't like to put the foot in a proper position. So he would walk with hyper arch. He would walk creating a cavus foot. If the patient has got tibialis posterior injury or rupture, this patient would walk with the high creation of artificially creates a cavus foot, and he doesn't like to put the foot on the ground. So we should be able to differentiate cavus foot gait with the which is not painful, which has got a lateral thrust, but there is a gait where patient is himself maintaining the foot into a cavus position, which is painful gait, and there the pain is on a medial side. There is no lateral thrust. Patient likes to walk patient loves to walk like this, and in a cavus foot, in a high arch, you have a lateral thrust while patient is walk. So these two are one of the important things. So once this evaluation is over, you do certain special tests, and these special tests are very, very important for foot and ankle clinical examination. I am going to show you various special tests which you do for foot and ankle examinations. Now, those for the ligaments, the syndesmotic ligament, you want to look at the syndesmotic ligament special test. There are three tests rather. So one is a calf squeeze test. So at the middle of the calf, if you compress, then patient would have pain at the level of syndesmotic ligament. This is not a reliable test, but this is one of the tests described for syndesmotic injury. The second test described for syndesmotic injury, which is more sensitive, is external rotation test. Now, mind you, whenever you are doing external rotation with the foot into neutral position, you are holding the tibia with one hand and you are externally rotating foot. Now, if the foot is into neutral position, you are evaluating deltoid. So if you want to evaluate syndesmosis, then you have to put the foot and ankle into little dorsiflexion, and then you need to do external rotation stress test. You got it? So external rotation stress test is one of the very important stress tests to know about the integrity of syndesmotic ligament. But if you do it in a neutral position or maybe slight plantar flexion, you are evaluating deltoid. If you do it into dorsiflexion and then you do it, then you are evaluating the syndesmotic ligament. And the third test for syndesmotic ligament injury is cross leg test, where you ask patient to put in the foot on the opposite limb. And is that okay?
Just one query. Repeat.
Can
you repeat stress test? Stress test, repeat करो पैसा.
Hello.
Hello.
Sir, kindly repeat the stress tests. Test 1 and test 2.
Okay. So, if you are maintaining your ankle into slight plantar flexion and dorsiflexion, plantar flexion or a neutral position, and if you are doing external rotation stress test, you are essentially evaluating deltoid ligament. But if you really want to evaluate the syndesmotic ligament injury, you have to open up the syndesmosis by doing dorsiflexion. It opens up the syndesmosis. It puts stress onto the syndesmotic ligament. And then you need to take your ankle and foot into the external rotation. And if patient has got pain and pain at the level of syndesmotic ligament, it is suggestive of syndesmotic injury. I think it is clear now.
Yes,
sir. Somebody
volunteer? Yes, sir.
Okay, thank you. The another test for syndesmotic injury is you want your patient to put the foot onto the opposite thigh. This is called cross leg test. This is supposed to be very, very sensitive test. And ask patient to relax and allow the foot and ankle to fall. In this position, not only syndesmosis is pressed, so there is a calf, there is a squeeze test, and there is an external rotation test. And this, when gives pain, it is quite sensitive test. So these three are syndesmotic ligament special tests. Now I'm going to show you the test for the anterior talofibular ligament and calcaneofibular ligament. So ATFL, when you want to test, patient is sitting on a table with a knee flex and ankle lying into 30 degrees of plantar flexion. And ask patient to relax. Make sure that patient is relaxed. And then you are holding the heel in your hand and you are, so this is what I am demonstrating is a lateral tilt test for calcaneofibular ligament. The patient is relaxed, plantar flexion, 30 degree plantar flexion of the ankle. You are holding the heel with one hand and tibia with the other hand, keeping your thumb over the talus, and then you are taking this whole heel into inversion and compare it with the opposite side. You could also take X-ray images and look for the lateral talar tilt test, which is specific for calcaneofibular. For a ATFL, patient is sitting with knee flex, ankle into 30 degree plantar flexion. I am holding heel with one hand. Patient's foot is resting over volar aspect of my forearm, and with one hand, either I am pushing tibia back and pulling heel front or reverse. So this is what I do. And at the same time, you look how much tibia how much talus translates anteriorly over the tibia, and whether there is any dimple happening at this level, and always compare it with the opposite side. So this is anterior talofibular ligament stress test, ATFL, or anterior drawer test. And this one is the lateral talus tilt test or stress test. Right? So these two are the tests for lateral ligament. Now I'm going to show you certain tests for tendo-Achilles. And for tendo-Achilles, there are two tests. One is Thompson's test, which tells you about the integrity of tendo-Achilles. You ask patient to either lie down prone or and then let the knee be flexed to 90 degrees and you press the calf and look at the plantar flexion of ankle. So if the tendo-Achilles is intact, you will find this to happen. This is Thompson's test. State case. And you also want to know about whether this patient has got only tendo-Achilles tightness or patient has got gastrocnemius tightness. So what you do is, in extension, you hold the heel. Most important is to put subtalar joint into neutral or inversion position. Very, very important. Because plano-valgus foot would give you spurious impression of good dorsiflexion. So you must put your subtalar joint into little bit of inversion. And then you look for your dorsiflexion. So this is the first step you do. And you look for your dorsiflexion with the knee in extension. And then look for the dorsiflexion with the knee in flexion. Normally in flexion, gastrocnemius gets fixed. So if you have increase into the dorsiflexion when you do flexion of ankle or dorsiflexion of the ankle, that means gastrocnemius is tight. When you have no increase into the restricted dorsiflexion, either into flexion at the knee or extension at the knee, that means both gastrocnemius as well as tendo-Achilles are tight. Right? And accordingly, you take a call whether you want to do tendo-Achilles lengthening or you want to do gastrocnemius. Then there are special tests for flat foot and cavus foot. I need something 2.5 centimeter height or something. Okay, for a flat foot, what you want to see are two important tests. One test is where you want to see too many toes tight. Nirav, if you could turn around. Nirav, focus down. Maybe you could sit down. So the camera is focusing onto the posterior aspect of the heel. Focus here. And normally when you see from the behind, you should be able to see 1.5 toes. If there is a flat foot with heel valgus, you would be able to see 3-4 toes. And that is what is called too many toes sign. Here, flat foot. So suppose there is a valgus. This is how you would be able to see more number of toes. Do you have a perfect focusing? Are you able to see?
Yes, sir. Yes, sir.
This is how you see too many toes. Otherwise, normally you see only 1 or 2 toes when you see from the behind. So this is one test called too many toes test sign for flat foot. And then the other test for the flat foot is single heel raise test. Now, single heel raise test is to know the integrity of tibialis posterior tendon. So for that, what you do, so show him completely. So you ask patient to put both the hands on the wall with a reasonable distance between wall and himself. In fact, this test you should first be doing and demonstrating to the patient and then ask patient to do this test. So with both the hands spread apart over the wall, you ask patient to lift up the painful or the affected limb. Suppose he has got right side which has got pain and problem. So the first thing he should be doing with the normal side. And with the normal side, what is he doing? He is flexing the knee completely. And you ask him to raise himself for 6 times consecutively on the toes. Please do it. 1, 2, 3, 4, 5, and 6. And you look how much fast, what is the speed he is able to do it. You look for whether he is having any pain. You ask this patient whether he is able to do it or he has to wait, or he says that no doctor, I have got pain. So this is first done on a normal side. Now you ask him to do on the affected side and look whether he is able to raise himself 6 to 7 times consecutively on affected side. So if you could flex your knee and try it on the opposite side, please. So if patient is having problem of tibialis posterior or arch problem, when tibialis posterior is broken, ruptured, he may not be able to do it. Secondly, when we lift ourselves, our heel goes into varus. That is a normal phenomenon because subtalar joint has to do that for us to lift ourselves. So if that is not happening, that also suggests that there is a fixed hindfoot valgus and patient's heel is not going in. So this is a very, very important test, single heel raise test for flat foot. For a cavus foot, you have a test called as Coleman block test. So Coleman block test is you take a block of about 2.5 centimeter height, and in a Coleman block test, what you want to see is the flexibility of hindfoot varus. In a flat foot, you have valgus. In a cavus foot, you have varus. So if the cavus foot is, or if the varus in the heel is dominated by or is because of 4-foot driven varus, if it is a 4-foot driven varus, then the heel which is there in varus would get corrected on a Coleman block test. If the varus is hindfoot driven, there is something in the hindfoot, then it may not get corrected with the Coleman block test. This is what essentially we want to do. So in that test, it's done. Patient's foot is allowed to, patient's first metatarsal is allowed to drop. Patient's first metatarsal is allowed to drop from the block. And while dropping this, there is a 4-foot varus. There is a hindfoot varus. And when patient drops the first ray and second ray, this varus gets corrected. That means this hindfoot varus is driven by 4-foot. And we need to focus on to 4-foot procedure because hindfoot is corrected. But if by dropping the first and second ray, patient's hindfoot varus is not getting corrected, that means it is a hindfoot driven varus. And we need to do hindfoot procedures as well. Nirav, if you could stand and show them. So essentially, patient is asked to drop the first and second ray from the block. And you look for the position of heel before and after. Is that clear to you all?
Yes, sir, clear.
Sir, what should be the height of a block?
So then comes TT stretch test and tight and calcaneus squeeze test. So you have a back flexor stretch test. Likewise, you also have a tarsal tunnel stretch test. So you want to put maximum stretch on a tarsal tunnel. That is by complete extension of the knee, complete dorsiflexion of the ankle, and eversion, dorsiflexion and eversion of the ankle, and dorsiflexion of all the toes. Now, this puts maximum stretch or pressure over tarsal tunnel. And if by this maneuver, patient winces, patient has a pain, reproduction of the symptoms at the level of tarsal tunnel, this is the surest test. And this has got high sensitivity. For me, if I am to operate on a tarsal tunnel, clinical symptoms, 1, and signs, EMG nerve conduction, 2, and tarsal tunnel stretch test, 3. If any 2 are positive, I will always operate. Otherwise, I will not operate. And similarly, you have your tinal sign where you percuss the nerve and look for the reproduction of the neuritic symptoms distally. So this is for the tarsal. For a calcaneal stress fracture, what you do is you squeeze calcaneus between 2 hands, and if there is a calcaneal stress fracture, patient will have pain. Then coming to the forefoot test, you need to look for instability of first tarso-metatarsal joint. And this is being looked by, so you hold all the metatarsal in one hand and hold first metatarsal proximal to tarso-metatarsal joint with another hand, and you manipulate the first tarso-metatarsal joint vis-a-vis other joints and see how much lax this joint is. So if it is too much lax, then we need to address this joint first when we are dealing with the hallux valgus problems. We'll talk about it. So if this tarso-metatarsal joint is unstable, we have to deal with that joint first. We don't go ahead and do hallux valgus corrective procedure. Here we go and do corrective procedures at the level where joint is hypermobile. Then you need to test metatarsophalangeal joint, PIP joints for the instability. And instability testing of this joint is by what is called as latchment test. You hold the joint you want to test proximally, and then you hold the joint which you want to test distally. While doing this test, your thumb is over the joint, and then you manipulate joint into dorsal and plantar direction, and at the same time you palpate with your thumb that how much joint is getting up and down. Similarly, you can do that for the second, third, or for the PIP joint. You manipulate the distal part of the joint and at the same time palpate how much laxity is seen into the joint. This is called latchment test. For the Morton's neuroma, you have Mulder's click, where you are holding the fourth and fifth metatarsal in one hand and first and second in other hand, and you are pressing them together. Not only you are pressing them, but you are also manipulating them into dorsiflexion, plantarflexion. And if the neuroma, when slides between two metatarsals, it gives pain and production of the similar symptoms. So these, I guess, are the special tests. I don't think I have missed any. If anybody has anything in the mind, you can just let me know. But these are the special tests. So once you carry out the special test, the last part of your foot and ankle examination is the examination of footwear. Because footwear and orthotics are very important to be evaluated. So when you evaluate your footwear, so you look at the shape and size of your footwear vis-a-vis shape and size of your foot. That is very important. Then you look at the wear and tear which you see all around the footwear. In a planus foot patient, there would be wear and tear which will be on a medial side. And this whole footwear would be deviated medially. For a cavus foot, there would be wear and tear on an can you close the door? On a lateral aspect. For a foot where there is equinus deformity, or a foot where you have a hexagonal deformity, you may have some wear and tear here. In a foot where you have great equines deformity, you also have wear and tear knee. If you have some toe deformities, there may be some wear and tear. So you look for the wear and tear into the foot. Shape of the foot vis-a-vis shape of the footwear, and wear and tear. You look at the creases. Where all are the creases? There could be multiple creases. That means this patient has got a very lax foot. If there could be no crease, that means the footwear is a very, very strong footwear, is not allowing pliability of the foot itself. You look at the laces, how many laces are there, if the laces are there or not, and whether the laces are properly tied or not. You look into the foot, whether there is any orthotics or not, and whether if orthotics are there, whether orthotics have got wear and tear, whether orthotics are properly placed at the proper position or not. Sometimes and then there are some tests which I'll just come with. Look at the counter of the heel. Heel counter is a very, very important, because this is the one area which grips your heel. If that is not proper, this patient may not have good grip by the footwear. And then there are 3 tests which you do for the footwear. And these 3 tests are lipstick test, flexion test, and a torsion test. So flexion test is you hold the footwear with one hand and you try to flex this foot. Normally, this footwear should get flexed at the level of forefoot and midfoot. This is the normal area where there should be flex. But if this footwear is getting flexed at multiple levels or at the different level, that means there is some instability, some problem either in the footwear or in the foot. Then comes a torsion test. Now, torsion test is, you do it by holding the footwear from one hand, and with the other hand, you try to twist the footwear. If this footwear is twisting very easily, that means it's a very soft footwear, very dangerous for the patients. If this footwear is not at all flexible, not at all twisting, I think it would be a very stiff footwear, and it could be a dangerous footwear for a diabetic patient, because he may not have any ply of the footwear. So the torsion test, the flexion test, and the third test is a lipstick test. So many patients, they have got some orthotics. Say patient has got first MTP base ulcer, and you got a metatarsal pad putting. You got a metatarsal pad putting at the plantar aspect of the foot. How do you know whether that orthotics is really placed into the right position or not? So very simple thing would be that you put in a lipstick, right, at the level at the level of the pad which is stuck into the foot, and then ask patient to stand over the footwear and then see where are the lipstick marks. And if lipstick marks are at proper position or they are not proper position, you would be able to appreciate. So these 3 are the footwear tests. So essentially, this finishes the foot and ankle clinical examination. Any question anybody has, I am happy to answer. I think we've taken a good time talking about the clinical examination, but it was probably required. So any question? Just close it.
Any question? Any? Okay.
Hello.
Yeah.
Hello.
Yes.
So regarding this lipstick test, so if there is callus under the metatarsal head, so where to mark the lipstick at the level of metatarsal heads on the
No,
sole?
you mark lipstick in the orthotics. You mark lipstick in the orthotics, whether the proper placement is there or not. Suppose you have a doubt that this medial arch, this patient has got a cavus in your medial arch is not essentially correct, not supporting the cavus. See, for a planus foot also, you use arch support. For a cavus foot also, you use arch support. For a cavus foot, your arch support is little high because it is supporting the cavus and reducing load on that arch.
Yeah.
For a flat foot, you have a arch support which is correcting the flat foot, right? So that is the difference. So you want to see whether this arch support is properly applied or whether it is acting or not. You take a lipstick and put in a lipstick over the orthotics, over the arch area, and then see whether that similar area impression is seen on the foot or not. Got it?
Okay. Yeah. Okay.
So I'm just looking into okay, what should be the height of block? 2.5 centimeter. Okay, is there any particular test for metatarsalgia? Uh, Metatarsalgia is not a diagnosis. We will take a talk onto metatarsalgia. Metatarsalgia is a symptom. Right? So it is a symptom which is because of so many conditions. So when we speak about the forefoot issues, we will talk about this, but metatarsal, there is no test for a symptom, you know. If metatarsalgia is because of a hammer toe, you look whether the hammer toe is correctable or fixed. If metatarsalgia is because of Morton's neuroma, you look for the test for the Morton's neuroma, Mulder's click or compression test. So this is how it is. But it is not that that there is a okay. Sesamoiditis is quite common a problem. Uh, just yesterday, uh, somebody told me that whenever you see some good case, you should be uh, taking a case video. I could not take the case video because he was a doctor accompanied by 3 orthopedic surgeons and he had a diabetic foot with recurrent ulcer over the plantar aspect of first metatarsal. Plantar aspect of first metatarsal. And because and he underwent two plastic surgery. They did some flap or something. It never worked. Why was it? It was because he was having a plano valgus foot. He had a flat foot with valgus. So this patient, I told them that we need correction of the flat, and he also has a tendo Achilles tightness. So I told them that we are correcting the plano valgus foot, but I'm sure he's going to need sesamoid excision because it is the pressure of the sesamoid because of the planus and because of the tight tendo Achilles, which is not allowing ulcer to heal. So sesamoiditis is one of the common problem, and we see it in sportsmen, we see in diabetic patient where because of the pressure this problem occurs. Differentiation between insertional tendoachilles tendinitis and Achilles tendinitis. Oh, I think Achilles tendinitis itself is divided into two, insertional and non-insertional. So non-insertional is above 2 centimeter above the level of insertion, and insertional is at the level of insertion. So I think it makes the question easy. Is there a pro forma for detailed foot and ankle so that beginners can start with that? Okay, so pro forma for foot and ankle examination. Okay, I'll formulate a pro forma and I'll put a PDF into our WhatsApp group. Okay. How to elect cross fluctuation. Oh, it's very simple. You know, when you have a swelling and you want to evaluate for the cross fluctuation, you need to put two index finger onto the swelling, two index finger onto the swelling, and you press one and palpate for the fluctuation under the pulp of the other one. So you push one and palpate for the fluctuation on the opposite side, or you do this way and 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 palpate for the fluctuation on the opposite. Okay.
Sir, good afternoon.
Very good afternoon. Please go ahead.
So, Dr. Rajiv call here, sir. Just wanted to know, is there anything for, sir, anything for accessory navicular, cartilaginous or bony, any particular test that we do?
No. It is like when accessory navicular could be there, which might have united with the original bone, then you will find only just a bulge. And if there is insertional tibialis posterior tendinitis, you may find it tender. Uh, if the accessory navicular is not united with the original bone, and if it has fractured, when you do the palpation, you may be able to appreciate some movement of that bone. So many times you have fracture of the accessory navicular. So you may be able to palpate movement of the accessory navicular when you push it. Uh, clinical, okay, then, okay, just a minute. How often you get an ankle MRI for ankle sprain, especially for ATFL injury? What are your indications for? So we are going to discuss it in uh, ligament injury. So just be patient. Clinical diagnosis of synovitis, area 12. That's a fantastic question. So ankle synovitis to begin with, always it would be into the anterolateral gutter of the ankle. So if anterolateral gutter of the ankle has fullness and tenderness, you can diagnose it as ankle synovitis. The subtalar synovitis is along the subtalar joint. It's a horseshoe shaped swelling. And to begin with, it is onto the lateral aspect. So continuously it will follow the posterior facet of the subtalar joint. There would be swelling and there would be synovitis. So clinically, synovitis would have diffuse tenderness into major areas where the joint itself is passing. I have seen a few patients with boggy swelling on the lateral aspect of the ankle, non-tender swelling. Now these patients who have boggy swelling on a lateral aspect of ankle, mind you, could have lateral impingement of ankle because of subfibular impingement, because of valgus of the heel. So all those patients, there are two things which could be there. One is early synovitis of subtalar joint can present as such kind of swelling, and second is subfibular impingement because of plano-valgus foot can present like this. And how to differentiate this boy swelling onto the lateral aspect of ankle? Uh, we are going to talk onto uh, in a session of day-to-day foot and ankle problems. I am going to take up differential diagnosis, clinical differential diagnosis of subfibular pain and perifibular pain. Now, so there I am going to show you with the examples and pictures that how can you differentiate subfibular pain. But this is a very good question, and I am definitely going to uh, uh, deliberate onto this. Yeah, there's a question. There is a plantar plate tear. How to differentiate it from Morton's neuroma or metatarsal tightly? Okay, okay. So plantar plate is a thickening of the plantar aspect of metatarsophalangeal joint. And when this plantar plate has a tear, direct tenderness, you would be able to palpate direct tenderness at the metatarsophalangeal joint. So that is one. Second, plantar plate tear on one side might push the toe into other side. So what it results is called as a crossover toe. Crossover toe. So when you have a toe which has drifted into medial or lateral direction, believe me, it has to be because of plantar plate tear. The third thing is your latchment test. So when you are manipulating the distal phalanx over the middle phalanx over the proximal phalanx, or the proximal phalanx over the metatarsal head, when it goes, it slides up and down. That means your plantar plate is torn. So these three are the clinical diagnostic criteria about plantar plate tear. Morton's neuroma, you have a pain which is more on standing, more on wearing footwear, and pain is going into the medial and lateral aspect of adjoining toes. Pain gets radiating into this because it's a nerve which is supplying two tweaks, one to the inner aspect of one toe and inner aspect of the other toe. So pain goes there. So Morton's neuroma, it's a neuritic pain which has got something onto walking, and a patient is not able to wear the footwear. So it is very easy to differentiate Morton from plantar plate tear. Then tight tendo-Achilles, yes, I said that we did talk about that. How to treat it, we will talk about it when we talk about the forefoot issues. Clinical findings in subtalar joint arthritis, and which patient is it commonly seen apart from TOMA? Sometimes in OPD on X-ray we see arthritic changes in this joint and patient does not complain of non-specific pain while walking. How to approach? Okay, so this is bogging down to subtalar joint arthritis. The most common surgery I am doing in my practice, and you people when you become a foot and ankle surgeon or you would be doing foot and ankle practice, would be subtalar joint arthritis. And we have a session on arthritis of foot and ankle where we are going to discuss ankle arthritis, subtalar joint arthritis, and first metatarsophalangeal arthritis. So just wait, we will discuss it. Let it not be discussed on day one, everything. How to differentiate between impingement and ankle instability? Oh, that's a great question. That's a very good question. So, instability is while you are attempting locomotion. Instability is while you are attempting locomotion during standing posture, weight bearing posture. Impingement could be even without weight bearing. When patient does flexion and dorsiflexion, plantar flexion, there could be impingement. Impingement would be at the end of any movement. Instability would be like the moment you start doing that movement, it would be unstable. Instability by and large would be for an would be in a coronal plane, and impingement would be in a sagittal plane. So anterior ankle impingement, posterior ankle impingement. When patient does plantar flexion or hyperplantar flexion, patient would have pain at posterior aspect, and patient would have pain while moving the great toe because flexor hallucis longus gets impinged because of the posterior impingement of the, and anterolateral impingement is on dorsiflexion of the ankle, patient gets impingement. So that is about impingement and ankle instability. I was also thinking to go ahead with talk onto radiology, but I guess if you all are tired, we can just take it the next time. Hello, are you people all
Next
with
time,
me?
sir.
Yeah, next time,
So
next time.
we'll take it next time. Okay.
Next time.
Do you want to do suggest any book for examination? Yes, obviously, if you see my book, uh, Manual of Foot and Ankle, which has been translated into Chinese, Portuguese, and I think Arabic also. So that is the book. But then I'm going to give you a handout onto clinical uh, examination of foot and ankle. Yeah, Dr. Ravindra, please go ahead.
Hello.
Yes, Dr. Ravindra, go ahead.
So regarding the synovitis,
Hmm.
so only there will be tenderness along the anterolateral gutter of the ankle.
For ankle, to begin with, earliest this thing would be anterolateral gutter of the ankle, which would have pain, swelling, and tenderness, and diffuse swelling, boil swelling. For a subtalar joint, it would be at the level of posterior facet of subtalar joint. Thank you.
Okay.
Now, the last part of today's discussion is about these two cases. I guess all of you have seen these two cases, right?
Yes,
So
sir.
one case somebody else posted, and that is case for, if all other can be requested to mute the microphone, please. So thank you. So so you just close it. So the second case which somebody posted was a case of plantar heel pain, and it was like recalcitrant plantar heel pain. The most important thing is to see the mechanics of the patient, whether patient has got planus or cavus, and that requires to be corrected. Uh, some exercises, if they are not taught, plantar fascia stretching, tendo Achilles exercise, they are very important. Lifestyle modification is very important. We always worry about the weight gain, but I think we should be focusing on to amount of weight bearing time spent. I do not want to discuss out completely plantar heel pain, but I guess that beyond 3 to 4 months, if the plantar heel pain patient is not improving, you need to go for the secondary conservative modality. And these secondary conservative modalities are either complete non-weight bearing or a weight bearing in a below knee plaster or a boot or posterior tibial nerve block. This is what I practice a lot in my practice because I want to block the posterior tibial nerve. In the next session, I'm going to tell you how do you give local injection in plantar fasciitis, how do you give posterior tibial nerve block. So posterior tibial nerve, when you block it for about 2-3 weeks, the pain has a gate theory, and that gate is what you want to block and you want to aggressively mobilize. So this is another thing. You could use shockwave therapy. You could use radio frequency topaz coblation. So these are secondary conservative modalities, which if my patient is not responding beyond 4 to 6 months, is what I use in these patients. So that was about the second case. For the first case, that was not my case. Somebody sent me this case and wanted my opinion. But the most important thing, there are 2 or 3 of our team members who are very smart, and I was so happy that they picked it up, that it was a conversion of an ankle fracture into Charcot. And this is what you should be always watchful. Any trauma, any stress can induce process of conversion of a normal fracture into Charcot. And this patient had a conversion of ankle fracture into Charcot. And then being into the acute phase, some people thought that it is RSD. But in an acute Charcot, again, we do not want to go into a big controversy. But there is a controversy in the world. Majority of the people believe that acute Charcot just requires immobilization, uh, support, either a total contact cast or a total contact orthotics, and anti-resorptive medications, which again has low evidence, but alendronate is what I have used. Calcitonin is what people have used. I have not used calcitonin. Yeah. So yeah. So, support this patient with non-weight bearing, uh, uh, a total contact cast, or I always like to give a AFO non-weight bearing elevation and observe this patient closely. You do not know when acute stage converts into subacute or a chronic stage when you can go in and do surgery in form of tibiotalo-calcaneal fusion or ankle fusion. But today, there are many workers who feel that we should address Charcot in an acute stage if the deformity is going into such a stage that we may not be able to later on correct it swiftly. So that is what has been approach which of which I have taken up. Acute Charcot, if it is going very quickly onto deformation and uh, and then going into a stage where we may not be able to bring patient back into a good position where patient already would develop ulcer. I think it is that juncture one can also address acute Charcot. This is a controversial issue. We may not discuss it now. We'll discuss it at the level of when we discuss about the Charcot and diabetic foot. The most important thing to be kept in the mind is that ankle fracture in a diabetic patient, whenever that patient comes to your outdoor, always ask him, could you walk or stand after the injury? Majority of the patient with neuropathy would come to you 2 days down the line, 3 days down the line. They are able to stand and walk. They do not have much pain. They have just a swelling. Somebody has asked me, then how to explain pain? So look, 70% of neuropathy are painless. But then there are 30% of the cases where they lose sensation, but they do have pain. So don't think that the diabetic neuropathy means no pain. It could be painful as well. So many charcot do have some pain. So in such cases, when you have an ankle fracture in a diabetic patient, always ask, could you walk and stand after the injury? Always ask that patient that does he have a feeling of cushioned foot, or is he having a sensations like he is going to fall when he walks? Is he finding himself imbalanced? Is he finding his slippers and chappals coming out? He's not able to grip them. These are, or feeling of cold feet, these are typical features of neuropathy. You can evaluate the opposite side. You can evaluate, if you are in doubt, you can do biothesiometer examination. You can do monofilament examination. You could do nerve conduction studies if you are in doubt. But if you have slightest doubt that this patient has got a neuropathy, then you will have to be very, very much watchful for failure of your fixation. You need to act before your fixation fails. So, yeah, if this patient complains of severe foot burning sensation, then also it could be a neuropathy. It doesn't mean that neuropathy cannot be painless. So, next class uh, is I'm thinking if you all are okay, because we have to cover a lot. I was to cover 12 titles in total, and then after interaction with you, it has gone to 22 total titles. So I'm looking at 18 to 20 classes, and we want to finish it by May. So maybe if you all are okay, we can have a second class by 8:30 p.m. Uh, or say 9 p.m., 8:30 p.m. on Tuesday. So will that be okay? Or it could be
Okay.
8:45?
Okay, sir.
8:40.
Okay, sir.
Okay.
8:45.
So 8:45, and then we will discuss radiology in foot and ankle. We'll discuss MRI, how to read MRI in foot and ankle, and if time permits, we will discuss on to uh, some injections and blocks in foot and ankle. Right? So somebody wants it at 9 after 9. Now you see, friends, uh, my my day starts very early by 4:35, and I go to bed normally by 10. So this 9 p.m. could be a little late for me. 8:30 is what makes me most comfortable. We can settle down between 8:30 and 9 by 8:45, because normally I go to bed by 10 and I start my day early in the morning, so that would be really difficult. Beyond 11 you will find me yawning, so maybe we keep it 8:45 to 10:30, 10:45, please.
Okay, sir.
Thank
Yes,
you.
sir.
Thank you. Yes, somebody said we will adjust for you. Thank you very much for that. So, so that was about the two cases, and every session we will end with one or two cases. If you have posted, fair enough. If you have not posted, whatever good case I see in the OPD, I will record, and with all x-rays and all this thing, and we will discuss that case. Okay. So every time we'll have one or two case discussion, and in between some important common surgery comes, then also I'll try to record, and I'll try to show you. Okay, so anything else now?
Sir, can we get this today record session because examination
I
and
think it is Neeraj sir's and Ashok
okay.
sir's prerogative, but you drop a message in this group.
Yes, sir.
They are
Okay.
always there, and they would give you the recorded session and access to it for 3 months. My book can be bought on Amazon. It is available on Amazon.
Okay.
But mind you, this book was written in 2014-15. So science is not left stale. So just whatever scientific sentences I have written, you just take it with a pinch of salt. Don't believe into everything which I have written, because the book was written in 2014-15. But certain basic things are there. They are there to stay. So it would be useful to you. Okay, so we close here. Anything else? Thank you all. Thank you very much.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you, Neeraj bhai. Thank you, Ashok ji.
Thank you.
Thank you.
Thank you, Neeraj sir, Ashok sir.
Bye bye.
Bye, sir.
Bye. Thank you. Close the meeting.
Yes, sir.